Hi everyone, it is 11 o'clock, so we're going to go ahead and get started. Um, can everyone hear me and see me okay, first of all? Yeah. Okay, so I put some housekeeping things in the chat, but just a reminder, please keep yourself muted throughout the presentation. It'll just limit distractions and noise. Feel free to use the chat for comments or questions that you may have throughout this presentation. And there will also be time for questions at the end. And then with your video, you can have it on or off, whatever your preference is. We just ask that you attend to the material being presented. Today, you are all here for the virtual speaker series. My name is Allie Shipman. I am the Parent to Parent Program Coordinator here at the CED, and you're all here today for the virtual speaker series session, Dental Care for Children and Youth with Special Healthcare Needs with Dr. Gina Graziani from the WVU Department of Pediatric Dentistry. So welcome, Dr. Graziani.
Hi, thank you so much. Before we get started, I'm going to share my screen and I have some polls to share, so there might be a little bit of moving things around. So let me share first and make sure that I've got it in the right spot. I think what to do that, sorry, I just had it working perfectly. Am I sharing screen? Let's go to screen 2. So I think if somebody raises their hand, if somebody can like shout out and let me know, because I'm having trouble seeing like Zoom and my presentation all at the same time, I would just love that. So can you see, can you see my slide?
The screen now.
Yes.
It says
Okay.
what we'll cover today.
Okay, let me go back to the beginning.
Okay.
I just had it set up so I could, maybe I can do that.
This one we see dental care for children and youth with special healthcare
Thank
needs.
you. That's correct. But you probably, I think I just need to get Zoom on this other side, and then maybe that'll make sense. Then I think I can see you and get it all set up.
Okay. I see half of the desktop and then the oral health survey or poll.
Okay, that's fine. Let me see if I can do this again. All right, what do you see now? Just the whole presentation, like just the slide?
Yeah, just the slide. Yep.
Okay, I can see you here and I can see my presentation. So this is perfect. All right, thank you so much. I was trying to mess up that before we got started and then I got kicked off somehow. So welcome everybody and good morning. Thank you so much for being here. My name is Gina Graziani. I'm a pediatric dentist with the WVU School of Dentistry and I work in Children's Hospital too. My main role is actually as an educator for dental hygiene students and pre-doctoral dental students, like those learning to become dentists, and then advanced care providers like residencies and different specialties of dentistry. And I just help them take care of the kiddos of the region, the state and surrounding areas. So we have about 75 minutes because I want to leave time for questions. Again, please, I would love to hear from you. I love connection and communicating, and you all have probably the best and most valuable advice. I'm under the impression, and this presentation was built because the audience, I believe, is mostly parents and caregivers and families with children with special healthcare needs or IDD. There could be providers on here too, and I'm happy to make all of your acquaintance. And again, thank you for creating this space for me to talk to you. I hope you find something educational and valuable. So we know dental care is just one of the most common challenges that you face, and you deserve practical, evidence-based solutions and strategies that you can use today. And I think you're going to see that from here. We'll also have some helpful content for the healthcare providers in the office or in the audience, excuse me. But this is an interactive session. I can't encourage you enough. I'm happy to see your faces. And if a hand goes up and I miss it, please, Allie, let me know. Went too far. Please go with my arrows. So what we'll cover today, what are the things, as you saw in the email, like I want to talk about why oral health matters in general. What are the challenges that you all are facing, and why they're common, and more importantly, sometimes why they're just not your fault. I would love to help try to look at strategies to reduce your dental anxiety as you enter the office with your child, and also your child's dental anxiety. How do we build home care routines that are going to work for you all and your family in your house and help improve oral health? How can we help maybe make dental appointments go a little bit more smoothly? And then finding the right providers and resources, because they're definitely out there. So hence the chat and why I needed to see. If you could, I would love for those of you that are here, maybe just drop in the chat how old your child is and maybe one word to think about. What has your dental experience for your child been so far? I mean, like, has it been awesome or frustrating, hopeful, overwhelming, overstimulating? So I'll give you guys just a minute to do that. Improving, both of you. I love the improving context. So sad that it's kind of been, maybe you've had some issues in the past, but it looks like maybe you're making headway, or maybe you found the right providers. There's a million things that could have worked. So Melina, Vanessa, thank you for responding. So Michelle, child's 22, good, but not equal. So the care that they're receiving that's a great recommendation. So my other children have been offered braces, but that's never really even been discussed for this child. 3, difficult. I hear this every single day. That is such a true feeling. 6 years old, smooth so far. So hooray. We have some wins and we have some areas that are opportunities that we really need to improve. So thank you all for doing that. Let's go. Also, if you have your phone, available, I have a QR code, and I just have a quick poll to say, what's been your challenge? You've given me a word. If you scan that, then I can we can talk about some of the results that you have. So what are your biggest challenges? Is it how overstimulating the dental office is, because it attacks all of our sensations? Or is it finding a dentist that, can create a dental home with you? Just anxiety and fear, whether it's your own or your child's. Oral hygiene at home. This one, I'm just having you choose your most one. Later in the session, you can choose several all at once. And then I have the responses. Move those over here. And I'll just give that another minute to come in. So far, about 50% are saying finding a dentist who understands my child's needs. And you'll see that's one of the top 2 issues nationally that we have, not just here in West Virginia. Another one's been about dental anxiety and fear. I think that's common among all populations, and maybe exacerbated in this population too, rightfully so. Sensory sensitivities, absolutely. That's coming through as well. So thank you guys for doing that. Get my screens back on. So why it matters, why are we having this discussion? Why was I invited to talk about it? And it's really just to understand how important oral health is in the scope of the human body, but especially our kiddos with special healthcare needs, and then different types of IDD. So as a national quick lens and scope, children that have special healthcare needs are about 4 times more likely to having unmet oral health need than their peers. So conditions that they are suffering from are going untreated. This is common with children and with adults. So routinely, this is three decades of data saying that this is continuing on, that dental care is typically their number 1 unmet need. And so it's, again, like, this is a system issue, and then how can we help fix it? I think one thing I want to take, or I hope you take away from this, is that you're not alone, and we're always looking for more solutions. This is a graph of that national data looking at how children can utilize dental services, what their oral disease looks like, what's their oral hygiene like at home, their unmet needs, and then these are all stratified by I have a developmental disability or I do not have a developmental disability. The good news is that looking at the first column, you can see that studies have shown that really preventive dental visits, or at least being seen once a year, we're 1 and 1 for whether or not you have some type of IDD. But then it starts to change when you're looking at how are we presenting in the clinic, and then what do our oral status look like, and then unmet needs. And you can see that they're stratified much differently. Most of these are all statistically significant, saying that if you have IDD, you have a higher risk of or presentation of dental cavities. You have a higher risk or presentation of gum bleeding, which would be like periodontal disease. And I see something in the chat. I'm going to come get you. And then presenting with toothaches, oral health needs in general, and then unmet oral health needs. Let me pop back through here. Do these trends continue as children age into teen and adult years? Yes, they do. It continues on. So that's like a national really quick snapshot that's very sobering in my mind. I kind of wanted to bring it back to Appalachia and our home here at West Virginia. I'm assuming most of you are here in the state or surrounding region. So there was a study that was released in 2023, Beyond the Waiting Room, the state of dental care access in West Virginia, because access to care, not even just finding the right dentist to help take care of you, but finding a dentist is a really challenging issue currently, and it has been. So this was a paper that really highlighted severe workforce shortages, economic challenges, and disparities in access to dental care, particularly impacting more vulnerable populations like those with medical complexities, special healthcare needs. So this was like it's kind of cool. It was like a secret shopper study. They made just cold calls to dental group or dental practices, dental organizations, asking about 4 different scenarios. So like 1 per call. So the caller might have said, "Hi, I have a child that has Medicaid insurance. How long will it take me to make a new patient visit?" And these are the 4 scenarios: a child with Medicaid insurance, a child with a disability, an adult with commercial insurance, or family self-pay. And what this graph is showing you is that for the child, the individual child with a disability, whether or not it was private insurance or they had Medicaid insurance, the time to get a new exam from the offices was, sometimes double, triple than any of the other the categories. So it was really highlighting how difficult it is for individuals with disabilities to get in. So what they saw from that, of those 48 connected calls, 15 say that they don't see patients with IDD, a third of them. I don't see them. And then what do? They refer you. They're going to refer you to some of the bigger institutions like WVU or Virginia Commonwealth or OSU, depending on where you're at, or just straight to WVU, like urgent care clinic. Of those that connected the call and said that they would see a patient with IDD, 14 of them, or 42%, had to either have a referral. So that means you have to start over in another place, or you automatically had to be sedated before any kind of evaluation. So that's also very sobering for me. Just that I've never even seen your patient, but I'm saying that you have to go ahead and be sedated. So what we're seeing too is that it will take on average about 200 days for the patient with IDD to receive any treatment. So it's 115 days until you get your new patient exam, and then it's another like 180 days until you're going to be able to receive treatment. So 200 days. And in that time, what's going to happen to the quality of oral health care? It's probably going to decline the entire time. So this was a really great study that I hope is going to bring a lot of change with, the Oral Health Coalition and all of the bodies that are helping lobbying for oral health care for children and adults, and especially those with medical complexities. Dr. Sean Boyens is somebody who did that, and I've learned so much from him about public policy. It was a really great study. Now, I've given you lots of sobering things. I want you to know that there are bodies out there that are fighting for you, and that we have made some change. Is it enough change? Of course it's not, but it's nice to know that we're moving in the right directions, because when I tell you that data has been out there for 3 decades saying that we're not receiving the oral health care that we need, that's a problem. Like, what's been happening? So back in 2017, and this has been updated since then, the National Council on Disability really looked at oral health in context with patients with special healthcare needs, and identified a lot of troubling factors. Yes, thank you, Michelle. I'll tell you what those mean in just a second. They identified a lot of troubling factors, which included the American Dental Association, the Principle of Ethics, that's what PO means, and then the Code of Professional Conduct. So how dentists like myself, like when we become dentists, what do we sign up for? What are our ethical responsibilities and our code of conduct? It did not include anything about prohibiting a dental practitioner from refusing to see a patient based on a disability status. It didn't exist. Additionally, they were looking at the accrediting bodies for our educational platform. So Commission on Dental Accreditation is CODA. And they saw that there was no requirement for students to be mandated in training or competent in training or treating patients with IDD. They highlighted again lack of access to care, and then healthcare coverage was also an issue. So there was a response to the American Dental Association and the Commission on Dental Accreditation, who overseeing educating body. They took this super seriously and immediately made changes. So the American Dental Association changed their professional code of conduct and ethical statements to include that, now it explicitly prohibits dentists or providers, oral healthcare providers, from denying patients care in a dental home based on their disability status. Also, the Commission on Dental Accreditation now has a standard in their guidelines that dental education societies, the schools, have to meet in order to be an accredited institution about learning to manage patients with disabilities, IDD, and special healthcare needs. So it's not enough, obviously, because we continue seeing the same data, but it's a step in the right direction. So again, back to why does oral health matter? Well, oral health is overall health. So there's a big saying in dentistry that the mouth is a window to the body. So things that are happening in the body can sometimes present in the oral cavity. So during dental examinations, we may pick up different signs and symptoms that can lead to a systemic diagnosis. So oral health isn't separate from overall health. It's deeply connected to nutrition and growth. So if we have cavities and our teeth are hurting, not only are we hurting, but we're not sleeping, we're not developing, we're not eating the foods that we need to be to make sure that we're gaining the sustenance and we're growing. Speech and communication. So untreated dental issues could cause issues with communication. Behavioral and sleep patterns I've already talked about. And then oral bacteria, it can enter the bloodstream and start to exacerbate or cause different types of chronic diseases. And so this is a slide just giving like super specific examples of common types of bacteria that are in the mouth can get into our bloodstream and go all over our body and help exacerbate a lot of other types of common chronic diseases. For example, Alzheimer, cardiovascular disease, different types of cancer, diabetes. So chronic inflammation is chronic inflammation, whether it's in your finger or it's in your gums. So it's really important to take care of our overall health. So I hear this super often every single day in the clinic, like parents are being like, I just didn't know where to start. Every dentist said they couldn't handle my son. So, parents are frustrated, they're sad, they're scared out there, and they're just looking for help. And this quote really represents this experience of just thousands of families, the shared experience. And research is consistently showing that finding that willing and trained oral health provider is one of the top 2 barriers to care. So understanding, I'm doom and gloom. I've talked about challenges. Like, let's understand the challenges a little bit. What makes dental care harder for us, and why is it nobody's fault? Like, genuinely, this is a multifactorial issue on many different levels. So this slide names the single most common barrier for families, which is the sensory environment in dental offices. If you stop and think about it, the dental environment is an assault on all of our senses. So there are super bright lights, and then I have to lay down in a vulnerable position. You have to shine this bright light in my face. Everything tastes weird. Everything smells weird. Everything sounds really weird. I don't like how everything like feels on my skin. It's a really, really difficult and vulnerable experience. So it can be super distressing to all different kinds of kiddos. Another thing, the suction too. I'm going to spray water in those tastes, and then the suction, like that's a different sensation as well. So what's critical for both parents and providers to understand is that all of these responses are neurological as well as behavioral. So children, which studies have shown that children with autism spectrum disorder have a sensory over responsivity, and they display active, like more primary activation in the amygdala. So it can just be kind of hard for children to interpret this and then filter out incoming sensory issues. So it's just like it's overstimulation in the entire way. So I also like for parents and providers to understand like meltdowns in the dental chair, like that's not a tantrum for me in this population, or it's just children. Just think we have to create the spaces to understand what's happening and understand how to help. And some of the help that we'll talk about later are really easy things to do, like lower lights, etc. We'll get to that. So the solution overall, like sometimes it's not reasoning, it's not redirection, and it's not reinforcement. For some, yes. For others, no. The solution could just be modifying the environment to make it more palatable for children. Behavioral needs in the dental setting. So this is like a needs-based framing deliberately. We don't describe children as difficult or non-compliant. Instead, we name the support they need and we normalize that. Okay, like that's just, I think that's just like basic human connection. Whether or not you have a medical complexity, it's difficult for many people to go to the dental office. So help me understand what your needs are. Help me what would make this successful, and I'm going to help try to create that. And more than that, I'm going to make that okay. It's not about equality, it's about equity, right? Like person A might need more than person B, or might need something different. So dental anxiety in children with special health care needs just operates through different mechanisms than typical fear. Again, neurotypical children may fear something unknown or have a specific painful memory, but children with neurodivergence or other developmental conditions could experience anxiety driven again by sensory overload or difficult with transitions, or impaired habituation. For example, a lot of times we use desensitization appointments. So come just for 5 minutes and see what my environment's like. And, nothing else is going to happen. We're going to try to make this as easy as possible. That may work for some kids, but that might not be able to work for those who have impaired neural habituation. It's just kind of that same, overstimulation the whole time. So I still think it's worth for providers to offer adaptations that include desensitization visits, because it could help. And studies have shown that, they do become accepted responses, and you might get an improvement of acceptance and improved behavior for your dental visit. Another thing to think about, shorter appointments as much as you can. And there's only so much you can do in shorter appointments, but shorter appointments, typically AM appointments, or whenever people are feeling the freshest. Maybe it's after nap time, I don't know. Consistent staff, if they're used to seeing the same people over and over again, even consistent operatories, consistent environmental cues. Consistency is consistent, I think consistency really helps make successful environments. Um, do with our medical complexities and the medications that we have to take, then those are all going to have an effect on our oral health and our oral flora. So a lot of medications for different types of special healthcare needs can affect both the gums and the teeth. So historically, anti-epileptics or seizure medications can cause a lot of gum overgrowth. They do. It's also exacerbated because maybe we aren't able to do oral health practices at home. Other things like stimulants, antipsychotics, lots of medications, like if you look at the side effects, xerostomia, that's dry mouth. I mean, like 98% of medications out there can cause some type of dry mouth, which that increases your cavity and your periodontal risk because you don't have the saliva on board that's buffering your teeth and the acids that go in your mouth. A lot of, rightfully so, pediatric liquid, like the suspension medications, are sweet so that they're more palatable and more accepted in taking day to day. So many of them have some kind of sugar. You can talk to your pharmacist about getting a sugar-free option, but that might be really difficult because now you've changed this medication that they've been taking, their entire lives, or et cetera. Like they're not used to it. But if you can't do that, then you could also consider maybe just rinsing with water afterwards or wiping the mouth out, and that can help maintain a good palatable flora. Communication differences in the dental chair. So it's hard for children in general to communicate. It's hard for adults to communicate how we're feeling, right? So it's even more difficult for children, and then more difficult maybe potentially with those with special healthcare needs, especially if they're nonverbal. So you could use different devices or nonverbal cues to understand how they're feeling, especially if it's like pain or discomfort. More often than not, I'm inquiring with the guardian about, have there been any behavioral changes? Like, are we not sleeping like we normally don't sleep, or are we not sleeping more than we don't normally sleep? What about eating? Are we always a picky eater? Does it seem worse or better, or has it changed? Maybe more irritability. Sometimes there could be like slapping on the face, pinching, hitting the face, or fingers in mouth all the time. If children are able to, you can use those AAC devices or the picture, the PECs, the expressive communication to kind of point like lots of pain, or I have a sad face, that might help too. So as you're the expert on a child's communication, you're their caregiver and helping take care of them all the time. I'm going to look to you. Help me understand, what does this mean? What do you think? So you're their number one advocate, and help us help them by understanding, how to communicate and what's working for you. Access, we've already alluded to the fact that, only 1 in 10 general dentists feel comfortable treating patients with special healthcare needs. Most report feeling unprepared. This is a little bit, some of this is from an older study. It's improved a little bit, but really not so much. All the workforce numbers are really sobering. So only 25% of general dentists say that they've had hands-on educational experience with these patients during dental school. Again, this was from the Journal on Dental Education 2004, so it should have improved. But I still feel like it maintains to be low. Among general dentists who do not treat patients with developmental disability, 70% say that it's because of a behavioral management concern. 50% say they just weren't trained very well. And then 40% cite the severity of the patient's condition. Sometimes it takes more than one oral health care provider to take care of our kids. For instance, you might have a dental home that does exams and potentially cleanings, and you're seeing them, once every 3 to 6 months. But when it comes time for treatment and we require sedation, that's outside of their skill set. So they'll send you to one of the specialists. So it takes a village to raise our kids. Do consider that, there are many health shortage areas. So especially in rural health areas, which, West Virginia is mostly just a rural area, if not 100% rural. And so that makes things difficult as well. It is encouraging that 100% of pediatric dentists almost 99.5, do treat patients with special healthcare needs. But the kicker is they're unevenly distributed throughout the country. So even in our state, we have less than 20. We might be to 20 now. And the majority of those are like here in Morgantown, and then the rest are like Charleston, Huntington area. There used to be none out in the Eastern Panhandle. So even though you have those specialists, that's very few specialists for very many children that are out there. So it is good news that WVU did start a pediatric dental residency with the hopes of increasing the pediatric dental specialists that are going to stay within the state. 2 are going to finish this year, and they're staying in the state. So we're really excited about that. Oops, did I skip one? Okay, and this doesn't have a ton of context to patients with special healthcare needs, but I still think it's important that you see how your state is doing. So this was the 2024 West Virginia Children's Oral Health Report Card. There's too many F's on there, too many D's. It shows room for opportunities for growth and room for improvement. And one thing I really like to highlight is the children age 1 to 2 enrolled in Medicaid who received a preventive dental care through Medicaid, 13%. When I first came back to West Virginia, this was in 2019, 2020, this was at like 2 to 3%. So it's improved some, but it is still drastically low. So the American Academy of Pediatric Dentistry advocates, and the American Academy of Pediatrics advocates, that dental homes should be established by age 1. Okay, so age 1, no matter what you heard it from me, this gospel. So sometimes you'll call a dental office and they'll say, we don't see kids until they're 3 to 5 years old. The parent hangs up the phone thinking, I don't have to get my kid checked out until 3 to 5. That's not accurate. And so I'm trying to teach the general dentists and specialists around the state that, as well as our dental students. I mean, I hammer it with them all the time, by age 1. So, and the goal of that is, it's not that we always anticipate finding dental caries or gingivitis. It's really to establish what oral health care should look like, what's oral hygiene looking like at home, and then dietary practices. So here's our first one. I'm going to see if I can copy this, and I can't. I might have to exit out to or I'll just do the QR code. That'll probably be easier than me exiting out and putting in the chat, if you don't mind. So here's one of another one. So which challenge resonates the most with you that we've talked about? You can choose more than one, I believe, on this one. I'm going to pull that up. So it's just allowing us to reflect on what we've heard and see what I just want to know, to gauge what challenges you really face the most. So again, kind of the same as before. The biggest one is the sensory. Thank you to those who responded. Sensory sensitivities in the dental office, and then medical complexity and medication effects. And then the other 2 are these are right behind. This is number 2. All of them. Communication is tough, and finding a trained and willing provider. So just as that summary on those 4 different topics, before we transition into solution, the key framing: everyone has these challenges, and there are evidence-based strategies to help address it. None of them are hopeless, and none of them are the family's fault. The system needs to change, and families can also build skills and can use tools that are really simple to make a difference, just starting in your homes. Before we get on into all the solutions, I really briefly thought it would be important to see, or kind of discuss, what are some things that you might see when you're looking in your child's mouth. And these can go, this is just an overall, but then sometimes just based on a few different diagnoses. So various types of medical complexities will present, obviously, with different things. One of the biggest ones is an increase in gingivitis and periodontal disease risk. And that's usually plaque mediated. So I have plaque on my teeth, and I can't brush my kiddos' teeth at home because it's difficult, and maybe they have a sensory processing issue, or just really oral avoidance. The plaque is going to accumulate over time, usually many years, but the plaque accumulates. The gum tissues are always inflamed. That chronic inflammation is going to start inflaming the bone. When the bone gets inflamed, it'll start to resorb. That's periodontal disease. And so that's typically an issue for older adults. But if you don't have bone to house your tooth, then you don't keep your tooth. Enamel hypoplasia. So this is really typical in congenital cardiac defects / also everybody. But I always say if you have something weird happen in one place in the body, something weird can happen somewhere else in the body. And so there's a big correlation of congenital heart defects and then disturbances in how our enamel forms. And that means that the enamel is typically weaker, so it's more prone to either fractures or to getting cavities. Dental cavities can be higher in various special healthcare needs diagnoses. Oral aversion and behavioral issues in accepting oral hygiene. So it just could be difficult. Potentially what we call malocclusions. Malocclusions could be an issue. So that just means that we're not biting the way that we want to bite, with teeth over top. Is our palate arched and narrow, or is it wide? Does it cause concern? Does the way that I'm biting also have issues with my airway? Sometimes if our upper jaw is really, really small, you might see we'll get to this in open bite, a forward tongue posture to help with breathing so that we're not, apneic. Anomalies in tooth development, maybe how it developed, the size it is, the shape it is, how it's coming into the mouth, and then how the overall arch forms. Bruxism and wear facets. So bruxism is tooth grinding. And then additionally, fractures of teeth and trauma. So autism spectrum disorder, these are adult mouths, not pediatric dental, pediatric mouths, but they're a really good indication of what does tooth grinding, mostly I think parents hear it a lot, the grinding of the teeth. Primary teeth are more susceptible than permanent teeth in grinding because permanent teeth have extra enamel. You can kind of grind through the enamel on primary teeth pretty quick. I see grinding in a majority of children, but yes, it is something that we see in children with special healthcare needs. This rarely is like an emergency, but it's something that we want to know about because sometimes tooth grinding can be associated with an undiagnosed reflux issue, potentially ADHD, or just in general, do we have any issues with our airway? Heavy plaque and bleeding can be common in patients with ASD because some of them, like oral hygiene, might be hard to accept, or they aren't able to brush independently. You might see crowding, so there's not enough room for our teeth. Increased overjet, meaning how far do our top teeth come from our bottom teeth, and then just bite differences. Restricted diets can also kind of exacerbate some of the oral health out there. I saw somebody pop into the chat. So low muscle tone is a barrier to properly, brushing independently for my son. Absolutely. No, low muscle tone can even affect how our whole skeleton is gonna grow and develop, and then potential airway issues. Patients with Down syndrome, one of the biggest oral health risks is periodontal disease. The good news is cavities are pretty low typically in patients with Down syndrome, but they're at a much higher risk of getting periodontal disease. And this isn't just plaque induced, it's immune dysfunction induced. So it's sort of like your immune system and the chronic inflammation is fighting the bone. So periodontal disease can be really aggressive in patients with Down syndrome. You might see fissured tongue. Very typically, patients with Down syndrome have macroglossia, or just a really big tongue. They typically have a really small jaw on the top and then a bigger one on the bottom, maybe open bite in the front, and then some mouth breathing. Mouth breathing can affect just the oral health status overall because it dries everything out and it changes the normal oral bacteria as well. Do consider that patients with Down syndrome, they may have some kind of associated congenital cardiac defect that dental or oral healthcare providers would want to know about to make sure we do or we do not need to take an antibiotic before treatment. The reason why we do that is to try to make sure that whenever we're doing a cleaning, the bacteria from our mouth, it's going to get into our bloodstream. And if we have those defects in our heart, all that bacteria that's now swimming in our blood, they can kind of attach to the heart structures, especially where the defect is, because blood doesn't flow very well through there, and it can cause infective endocarditis. So that's the purpose of, or a heart infection. That's the purpose of taking antibiotics. Another thing that's not on here is head stability. So we want to be cautious when we're at the dentist. Should we need to use some kind of active or passive protective stabilization, we really want to watch their necks because they have some instability sometimes here. CP or cerebral palsy, really likely to have what we call an anterior open bite. You can see in the picture there. That leads to the same kind of presentation of our mouth is open in the front and maybe our tongue is protruding. We could be mouth breathing, maybe not. You might see drooling pretty commonly. It's usually not an overproduction of saliva, but maybe an issue with how we're swallowing. So you might have OT on board to talk about swallowing patterns. Again, reflux potentially or grinding, we see a lot. Same kind of things, enamel defects, potential to trauma. We've already talked about epilepsy and the medicine and the potential for overgrowth. Do know that that overgrowth is usually very painless. It's usually pretty firm, but it can progress to the point where it covers the teeth in general. Seizure-related dental trauma could include, soft tissue or hard tissue injuries like biting my tongue or biting my lip or breaking my teeth. Mouth guards where they can tolerate is okay. It's just hard for people, especially children, to accept a mouth guard, especially when are we going to fall? We really don't know. It can just be an accident. We just trip. If you ever have a tooth that's knocked out that you can't find, you need to consider the possibility of going to the ED and getting a chest x-ray to make sure we didn't aspirate it, especially if you have a history of aspiration issues. So those are just really quick, what are some things that we see in patients with special healthcare needs when we do our exams? You can do your own exam at home as you help support oral healthcare as much as you can. So plaque starts to form where the tooth meets the gum. So that's where you're going to see a lot of problems when it comes to oral hygiene habits. So lifting the lip, just lip so you can see where the tooth meets the gum is the easiest way. So starting just at the top, what normal healthy baby teeth are going to look like are just bright white all the way around. The gums look nice and hard and pink as opposed to red and inflamed and bleeding when you brush. The next stage are these white spot lesions that are right by the gum line. You'll see them when you brush plaque off the teeth. White spots is kind of counterintuitive. You think, oh, it's white, so it must be really healthy. Well, these are really white spots, and they're cavities. They're the initial form of a cavity. So the cavity has leached some of the crystals out of the enamel. They've broken down, and so it changes how light reflects through it, and therefore it looks brighter white. This is a really important sign to know that your child is at a really high risk for continued cavity development. But the good news about this, as long as the enamel stays intact, the superficial enamel, you can treat these with, non-invasive techniques like improved oral hygiene and improved diet to slow things down, fluoride varnish treatments, potentially a silver diamine fluoride treatment to help kill bacteria. And then the fluorides strengthen the enamel. But with no care or no improved home habits, then those white spots, the subsurface lesion gets bigger and eventually the enamel breaks. And that's when you see these brown spots by the gum line. So the enamel's now broken. You can't go back. Again, you can still treat with non-invasive techniques like silver diamine fluoride again to help kill bacteria and stop cavity. But without, you would want to seek professional advice anytime, but definitely once we see these, for sure, this is something that maybe I can help slow down in the office. But once we get to more severe cases where, the entire crown is all cavitated or has a big cavity, or the cavities move to the nerve of the tooth, it's killed the nerve and now an infection is going to start. Those would require very typically a surgical intervention to make sure that we're maintaining health. So when we've already talked a little bit about communication and like nonverbal cues, and so I always hit this one a lot because I think especially if you see something happening in the mouth and you're like, oh gosh, what is it? If we can't say it hurts, just what are the behavior changes in your child that makes you think like, maybe this is something that is this oral health issue, like changes in diet, changes in sleeping pattern, more irritability, potentially like maybe some self-induced trauma around the face or fingers in the mouth. So hoping to reduce some fear and then build trust for your kids with the dentist, here are some evidence-based strategies to create ideally a more comfortable visit. So before we dive into those strategies, again, it's important to understand why standard approaches of dental anxiety often don't work. We've talked a little bit about the neurotypical child can normally respond well to reassurance and positive experiences and repeated exposures. But the brain habituates these and then it's like becomes less threatening because I know what to expect. But for neurodivergent children and children with developmental disabilities, that habituation isn't going to happen the same way in the brain. So sometimes repeated visits may or may not help. It just might look different. Excuse me. So the cycle kind of looks like this. If I have a bad experience at a dental office, then that's going to lead to avoidance. And that avoidance is going to lead to dental problems getting worse. And once the dental problem is worse, that next visit is likely going to be more invasive because something needs to happen. And then it's more distressing, which reinforces the avoidance all over again. So we're just going in this cycle of negative outcomes. So research shows that more than 3/4 of special healthcare needs children develop new cavities within 1 year after treatment under general anesthesia, especially those that don't access like routine follow-up. They're 4 times more likely to need a repeat general anesthetic event to maintain like oral health. That is very similar as well with children who do not have special needs. If you require a general anesthetic event in order to take care of teeth and do fillings or crowns, extractions, etc., then you're super high, like your cavity risk is really high and you're like 80% likely to have new cavities within a year because it becomes an uphill battle. So it is a little bit more exacerbated in patients with special healthcare needs. And we want to try to reduce general anesthetic events so that we can, because it's always risk versus benefit. So strategy 1, desensitization is the most extensively studied approach for children with special healthcare needs. Even though I've told you so many times that neural habituation might not work, we just study the crap out of this one. And there are good results. Like the University of Washington followed 168 children with autism spectrum disorder, and through graduated exposure found that about 77% achieved a minimum threshold dental exam within 1 to 2 visits, and 87.5 succeeded within 5 visits. So that's encouraging. And then what's even more encouraging, a 2-year follow-up found that 92% maintained examination tolerance, and 83% accepted toothbrush prophylaxis, meaning we helped them brush, not with like our zoomies. And then 77 tolerated a fluoride varnish, which is a really difficult thing. It tastes bad. It feels weird. You can't like wipe it off. That one's really hard. So at home, parents can start with small steps. I'm going to keep reinforcing this one. Using toys, like there are plenty of dental toys that are safe to count teeth, maybe outside, maybe that like on a different toy, or maybe you count stuffed animals. I usually count the toys' teeth, or I look up their nose for teeth, and then maybe I look at the parents first, and then maybe I'll start with the child, all for them to see how it goes, and it's going to be the same. Um, you could introduce electric toothbrushes. I mean, that's a very stimulating. The electric toothbrush is super stimulating, just especially for me in my front top teeth, because there's lots of nerve innervation there. So the sound first, maybe feeling it on the hand, maybe touching it to the face. Maybe you don't get to brush teeth, but the more that we become used to what that sounds like and what that is, and then eventually starting in areas and moving around, then I think that can help. Tell, show, do is probably like the number one thing that the pediatric dentists use. So 98% of AAPD members use this, and we use it at home. So I'm going to tell you what I'm going to do. I'm going to show you what I'm going to do, and I'm going to do what I'm going to do. Now there's like kind of like tell, feel, show, feel, do. So I'm going to tell you, tell me how you feel about that. What are you thinking? Okay. I'm going to show you. What do you think now? So again, desensitization, this is kind of an important thing as far as insurance coverage when we're talking about how that's a barrier. Lack of insurance because no treatment is performed. So insurance very typically doesn't cover these kind of visits. So parent advocates and policymakers are trying to change that. So if your office charges for them, know that investment's building in comfort and hopefully preventing far more expensive and traumatic emergency care later. Social stories and visual schedules. Again, it's consistency and maybe knowing what to expect. There's lots of versions. I have just a few on here. But social stories leverage the visual learning strengths that are common among patients that have developmental disabilities and neurodivergence. This is a behavior guidance best practice for pediatric dentistry that explicitly, it lists the picture, exchange communication system as an additional behavior guidance option. Usually a lot of these can be changed in the order so that because order is the other thing. Like I don't know, maybe, no, they can't put my bib on until I sit down in the seat. Just whatever works for your family and your provider. But the idea is to get them used to the environment, used to the steps that are going to happen, in the order that they're going to happen. So we have found through different meta-analyses that there is an improved cooperation in this. It does not go past me that I'm a mother of two, and that talking about, all of these things can be a little bit overwhelming of thinking that, oh my God, I have to do all these. You don't have to do all of these. You pick one thing at a time. So we'll talk about goal setting in a little bit. But if you can do it daily, maybe 2 weeks before the appointment, sometimes people recommend driving to the office and maybe doing a pass through. Here's another example. And this is a little bit like what I was talking about goal setting is break it down. So maybe one of our pictures is just brushing teeth. Well, think about how many steps go into brushing teeth. I have to get off the couch. I have to walk to the bathroom. I have to find my toothbrush. I have to wet my toothbrush. I have to put toothpaste on my toothbrush. So sometimes we set a goal for ourselves, and when we're not hitting it, we internally get really conflicted, maybe frustrated, maybe guilty, maybe we feel shameful. But I encourage you to stop that process of thinking and just back up and say, oh, well, maybe I'll get to that goal, but maybe I have to break it down into more mini goals, like turning the water on, putting toothpaste on. These are all little wins that we need to celebrate, as opposed to negating the fact that we're not getting to our big win. So as much as you need to break it down, there are social stories out there that are just about going to the dentist. You can create your own. There's also really good videos about children going to the dentist. Now, the only caveat is that might not be your dentist, but it might be some place to start, and you might take a tour through the office. Let's see what the waiting room looks like. Beyond that, just know I have done dental exams underneath chairs. I've done them in the waiting room. I've done them in the car. I've done them in the parking lot while walking. It's about how can I meet you where you need to be met, right? And then if I need something different, I desperately need it, I'll talk to you about that too. So we just kind of have to think outside of the box, but these are good places to start. Additional cards, I got these from the Centers of Excellence on Disability with WVU. These are common things. Maybe it's really hard to rate on a scale of how much pain it is, but I can pick a face or I can choose a color. And then where does it hurt? I can point on here. And then another one. So sensory adapted dental environment now has really strong clinical trial evidence for any single intervention in the population. I feel like those are like really big words, but they don't have to be anything super extravagant. We'll talk a little bit more about that. But if we can change the environment, it's going to help make we create this thing that we expect everybody should just kind of be okay with, but nobody's okay with the same thing. So there are small things that we can change in an environment that's going to cut stress and stress distractedly or dramatically. So the Children's Hospital in Los Angeles enrolled about 162 patients with autism spectrum disorder and did a randomized crossover design looking at the modifications of turning off overhead lights. They're awful. Maybe putting something on the ceiling that was calming, like an aquarium light and bubbles, like the noises were less and turned down, and maybe they were soothing. Maybe the dentist doesn't use the light over the chair because that, even though I only see light here, it's just still really bright. There's reflected light. Maybe I just only use my headlamp. Maybe a body wrap if like we like pressure, the X-ray lead unit, or some kind of wrap that makes them feel more secure. And the results were significant. They found significantly lower stress across all environments or all phases of the appointment. And then stress reduction began as soon as the children entered the room. So families and practices don't need to spend a lot to have this super specially equipped office for each individual. It's just like, what are the little things that we can do? Again, maybe it's sunglasses, maybe it's headphones, and what would they like? Maybe it's an iPad with their favorite show, kind of like having them look up right above them. We just have to get creative with it and listen to each other. So this slide is really framed as parent advocacy. Again, these aren't luxury accommodations that we're trying to create, but they are evidence-based. So AAPD members found that, again, almost 99% routinely do tell, show, do, 95 use positive reinforcement, and then 98 use rapport building skills. So really, if you can combine all of these successive approaches, then it's going to help improve like their objective behavior scale on something that we use, a Frankel behavioral scale. So I want to encourage you to advocate for your child with confidence. Print, email, verbalize, hey, this is something that could really help. Can we please be in that one room that we were in last time? Now, sometimes we don't document that, but we try to as much as we can. We'll talk about info sheets that you can bring about maybe what your child's triggers are or their medicines, and then, what you plan on bringing as far as maybe headphones or an iPad. So if you can have kind of the same look, the same feel, the same people, all of that's really gonna to help hopefully make a more successful visit, but also a less anxious visit. It's really important to know that when sedation and general anesthesia are appropriate and recommended tools to use, don't feel like this is a failure. Like, this is just me meeting you where your child needs to be met. Maybe we have an infection and we don't want them to get really sick, or they are really sick with this infection, and the best way to move forward would be doing a sedation or a general anesthetic event. I encourage that because it's meant to keep your patient or your child safe, and then hopefully create the most streamlined thing that we can in order for them to continue to accept oral health. But there are things that you can consider. Maybe, are there other strategies that we have tried that might work? For instance, could I try maybe a minimal sedation, like a medicine that I can drink just to get a loopy first? Can I try that? Is that an option? And it may or may not be, depending on how healthy or unhealthy your child is. But okay, so what kind of sedations are out there? Because maybe I'm not interested in my child being awake at all. Like, I really, really, really want to make sure they're totally asleep, etc. What does that look like? What will the visit look like in general? And what does recovery look like? So that you can walk in prepared, and maybe you can help, your child be prepared too. So just, if you'd like, in the chat, taking a break, letting us reflect on what we've learned. What is a strategy that you've tried? Maybe that's been successful or not successful. Is there anything else that you want to try? I'm going to get a drink of water. Okay, so yeah, it sounds like the social stories about going to the dentist have really helped. I hear that a lot from parents. We actually have one resident doing a research topic on this as well. So I'll be curious to see what else happens. So there's no single best right answer. Getting a reward after seeing the dentist, and that's really important too, right? That's a big thing. Like if we go to the dentist, we're going to get a reward there because there's so many things that happen there. But I think maintaining what you've promised. Sesame Street, yeah, we use a lot of Daniel Tiger. He goes to the dentist in my family. Sunglasses, yes. I think validating children's experiences while they're there, and like, because sometimes, you might have people that are just like, oh, I hate the dentist. And I usually respond with, I know, I understand, but we love you. And then a lot of times it's, I want to go home. And I'm like, me too. Me too. Let's go home. Let's do this so we can go home. Because those are all real feelings. I really like that our dentist lets them pick something to watch on TV in the exam room. Yes, that's that one. We had that in a private practice I used to work in out west. We're doing a renovation here right now, and I'm getting iPads for each of the units. However, I don't know if I can get them to pick their own separate thing. I'm still working on that one. Well, thank you so much for all of those. It's good to hear from you. It sounds like we're all kind of tracking. So building a home routine, how do you do it? If you have a child who isn't really associating well, we have our own stigma about brushing teeth whenever our child's not accepting it. And for the little ones, I kind of backpedal that. I'm like, so if you have an infant or somebody who's still in diapers, how is diaper changing? It's horrendous. I'm like, so do you still do it? Well, yeah. I'm like, do you still wipe their butt? And they're like, obviously. I'm like, because what happens if you don't, right? Like you're going to get a rash. Those things can be gnarly. They can make people really sick depending on how bad they get. So we've got to do it, even though the kids hate it. And so do you feel shame? Do you feel guilt? Do you feel trauma, when you wipe their butts? And they're like, now I think the light bulb is going off. And they're like, sometimes. But most of the time, no, it has to be done. I'm like, it's the same thing. It starts here, it ends there. So, we still have to clean the mouth, but for some reason, toothbrushing has become it is a really triggering event for parents whenever children don't want to do it. So how can I help them accept this as well as the child? So knee-to-knee positioning is a really wonderful thing. There's a little infographic down here. So the parent or guardian or caregiver is going to sit in one chair, and they're going to have the child on their lap with one leg on either side, kind of like they're giving them a big hug. And then you're going to lean down into the provider's lap. So the child kind of leans into their lap, and then the parent or guardian is going to hold the child's hand. It works wonders. I'm telling you what, because you can really do a good exam. It's, again, I make space for people being upset. It's okay. I know that I'm not going to hurt anything. I just want to look and see what's going on. So that's something that you can do at home if there's two people there that can help you. Otherwise, you can try reclining on a sofa or bed. Just watch for aspiration risks. Maybe you need to be a little bit more upright. If your child utilizes a wheelchair, sometimes you can recline those bad boys back, but just make sure you have head support. Hand over hand guidance is really a nice trust building tool. So we've all got, the toddlers or people, I can do it myself, obviously. So how do you support that? Because we want to encourage independence, but we also know they need help. So hand over hand is just allowing the child to do brushing, but your hand is with them, showing them how to do it. It's helping with motor movements, and it's helping making sure that we're getting teeth clean, but it's also allowing them their independence and showing that they can take care of themselves too. Tools that you can use at home, there's lots of different things to buy, right? There always are. So three-sided toothbrushes are helpful because they clean the cheek side of the tooth, the tongue side of the tooth, on the top of the tooth all at once. I have a picture coming up. Modified grip, so if dexterity is an issue, so you get the toothbrush is very typically the handle is very small, so it's hard to grip that and have dexterity. So you can enlarge that by using like pool noodles or a tennis ball, or putting it on a ruler if you just need a longer one. I didn't know this was out there, but I found out suction toothbrushes, especially if you're worried about aspiration risks. So you can brush your teeth and it has suction associated with it, and it removes saliva. Low foaming toothpaste, if the texture of toothpaste is really gross and they're having, it's like, I have families that come in, they're like, I have tried 35 different types of toothpaste. I have them all. And so, brushing is the most important thing because you're disrupting that plaque, that biofilm that causes cavities. But if you can add on a fluoridated toothpaste on top of it, that's nice. So here are just some examples. This one is just supposed to be a smaller head. So it's even, you might still need to use a baby toothbrush even as people get older because it's a little smaller and more acceptable. An automatic toothbrush, and it comes with different tips. A water pick. Here are some of the aids as far as dexterity and helping to handle things. And then this is the three-sided toothbrush where it cleans on the top and then on the sides of the teeth, because it's really hard to get the tongue side when we can't cooperate for oral hygiene. This is an auto brush. So I haven't read the research other than the manufacturer's research about how wonderful it is in removing plaque. But more and more, I get people that find that, with neurodivergent diagnoses, that these are an oral, like sensory processing, oral aversion issues. These are super well successful. It's very counterintuitive in my brain about like, how can you accept this whole mouthful of stuff in there with this foaming toothpaste? I think it does go faster though. Like it might be 30 seconds over 2 minutes or something. But I mean, I've seen a lot of good anecdotal reviews of like parents are like, no, actually my kiddo really accepts this. So again, I don't know how effective it is. I need to see more research on that, but I wanted to throw it out there because a little bit of something is going to be better than nothing. Oops, I need to hit chat. I see somebody got me. All right. Has a C handle. So the WVATS program at CED has a C handle that can clip onto the toothbrush for people to borrow and try out. That's a really wonderful data point. And then there's a link in the chat. Thanks, Melina. Fluoride, especially if we can't. Fluoride is in cavity prevention is important on top of the teeth. It is not important to swallow it or systemically. So it's like a topical medication, just like you put immunosporin on a cut, right? So if my child can't spit, can I use fluoride? Yes, you can. You're just going to alter the amount that you're going to use. So the AAPD goes a little bit by age, but I go by behavior as well. So if you're under 3, you want like a rice size, a barely smear there. You don't need much. And then you can try to wipe things out, but they're not able to spit. So if your child is older than that and still not able to spit, you can kind of keep doing the same thing. More is not better. You just need the tiniest amount. Older children that can spit, the 3 to 6, they can use more like a pea-size amount. That's all that I use personally myself. But you can use fluoride. You can use professionally applied fluorides at higher cavity risk. We usually recommend it more than once every 6 months or once a year, typically once every 3 months, depending on your cavity risk. You're welcome, Michelle. So another type of fluoride that's really kind of come up in the past 13 years here in the United States is silver diamine fluoride. This is a cavity arresting medicament. It's actually FDA approved for dentin hypersensitivity, but the silver in it is antibacterial, so it kills bacteria, which is what's causing the cavity. So that's also out there, and there are very few contraindications to using it, meaning like reasons why I wouldn't. So a diagnosis of like a systemic diagnosis isn't going to have it, but like a silver allergy, yeah, we're not going to use it. Or if you have ulcers in your mouth or mucositis, like yeah, we wouldn't use it yet, but it's out there. So fluoride products are totally fine to use, but if we're not going to be able to spit, just consider using a lot less of them. The connection between nutrition, medications, and oral health is especially significant for children with special healthcare needs. Those who receive nutrition through feeding tubes like G tubes or GJ tubes are not eating by mouth, obviously, or maybe they have taste, but for the purpose of this discussion, if we're not chewing inside our mouth, we're not stimulating removal of plaque, and we're not stimulating our gum tissues. What typically happens is that you get a really big buildup of tartar or calculus along all the teeth. It's kind of like think about barnacles on a ship, those really hard things. So the plaque just gets like mineralized, like fossilized onto your teeth. That can just cause chronic gum irritation. So we usually like to take it off around the gums. We've already talked about the thickened liquids and the sugary ones for medications, and just remember to wipe out. So when do you want to come see us? Well, if you do those like daily brushing routines and you start to see those white spots or brown spots, come see us. Come see us at least once every 6 months. More if we diagnose you as a higher risk, we're going to want to see you more. Red, swollen, bleeding gums, especially with routine brushing, or that's not going away. So those red, swollen, bleeding gums, maybe it's plaque induced by like we're not brushing really well in those areas. It could be maybe you had a virus and you just have ulcers on your gums, or it could be something else. Like, so if you improve your hygiene and it's not better in 2 weeks, then I'll want to see you back. Behavior changes. I have often some types of instances where parents present of like, something is going on and I'm just driving myself crazy and I can't figure it out. All my other specialists can't figure it out. Is it oral health? Can you just do the best you can and see if there's an issue in there? Obviously, anything that's visibly broken or big black holes, if there's any swelling in the mouth, outside of the mouth, then I definitely want to see you. So setting up for success before, during, and after your dental visit. This is a checklist of just some recommendations that we've already alluded to, maybe calling ahead. Some offices out there actually have a questionnaire for their new patients to help see like how can they best meet your needs. So they may send that to you, but additionally, you may call with your own questions and recommendations to create a successful appointment. If the first appointment a day is good for you, request that. If it's the first one after lunch or at the end of the day, request that. Make sure that you are preparing your child both before the visit with something like that social story, or giving them a kit to bring along of things that are going to bring them comfort, whether it's a stuffy or their own sunglasses or headphones or weighted blanket. Practice. We learn so much through play. Playing is so great. It creates connection between caregivers and children, and then reproducing that play in the office might be advantageous as well. The info sheet, we'll get to that. Bethany, give me 1 second. Drive by or visit the dental office beforehand. A tour is really great. And then maybe a reward that somebody else already mentioned that they do. So a question about, is staining from daily iron supplementation strictly cosmetic? Are there any concerns to dental health with iron supplements? There are not any concerns. Very typically, that's like an extrinsic type of staining on the outside. You can't usually remove it with just like with brushing your teeth at home. We typically have to kind of scratch it off of there a little bit. So really sometimes it's iron, like heavy laced iron foods. There's also like chromogenic bacteria staining. So like what they kind of put out stains on your teeth as well. But yeah, it's mostly just an extrinsic issue. You're very welcome. So during your visit, bring your info sheet. Talk about the breaks. This is your time. It's not the prep time. Like, you're the advocate now, right? Like, you're going to help me steer this appointment to be successful. I want you to communicate with me and with the dental team because I want to be there in the way that you need me to be there for you. Of course, communication goes both ways. If I can't deliver, I'm like, ooh, that one's a toughie. What else can we do? Maybe establish a signal for pausing. So I establish a signal when I'm doing procedures of a hand raise very often. Just as an example, like when you raise this hand, I am going to acknowledge it and I'm going to stop as quickly as I possibly can. And so when they raise it, like let's say I'm in the middle of an injection, I'm like, oh, I see your hand. Thank you so much for raising your hand. You must have your helper hands on and your listening ears. Thank you so much for putting those on. Like all I'm trying to do is finish this injection. And then it's like, whoop, okay, now did you remember what you wanted to tell me? Okay, tell me what you're going to tell me. And then like they've forgotten. And it's like, oh, that's okay. It's going to come back when it's important. So recognizing those and then those signals are really great. Sometimes we need to explain everything before we do. Other times that doesn't work. And it's like, oh, I think you're just stressing them out more. That's okay. We can do what you need us to do. If the visit isn't going well, that's okay too. Like if I ask parents a lot of time, especially in an emergency situation, if I am going to use a passive stabilization, like the blanket for the chair, I'm like, I spell out what it's going to look like, what we can anticipate. And if you feel uncomfortable at any time, I will stop. And here's my only caveat about when I cannot stop. And so like, then that way we're all on. There's no shame in being like, oh my God, I agreed to this and I'm actually not okay with that. Could we stop? Yes, we can stop. Absolutely. Share visit notes with your pediatrician. So after the visit, care coordination is real difficult with dentistry because dentistry grew up in a different house than medicine did, much to my chagrin. I wish all the dental advocates out there and the public policy makers are probably going to kill me on this one. But gosh, do I wish that we were more under the umbrella of medicine, because I think we would be having a different conversation about, the ease of what was going to happen. So care coordination is really important. Not a lot of dental providers, in fact, a minority, have access to a medical health care record. So they're blinded by that. They'll need to do consults and you can help streamline some of that. Maybe keep a binder. Let me tell you how much I love the parents that come in and they've got their medical binder with them and they know exactly. They're like, I know you don't have their medical record. Like, here's their list of medications. Here's what we changed to. Here's our specialist. And I'm like, God bless you. Can I scan that bad boy in and put it in their chart for us? And it's super helpful. But don't worry if you don't have it. We can send out our own types of consult, but sometimes it just delays things. Make sure you, if at all possible, schedule your next follow-up visit. That's one of the most important things about just patient compliance in general, myself included. I love when people schedule things out for me and I just put in my calendar, I totally forget about it. And it's like, oh, it was already done. It's just one of those things you can take off your plate. Additionally, no matter how difficult that day was, in your heart and in your child's heart, maybe we find a way to celebrate. We find something to celebrate. Hey, that was a hot mess and a disaster. It was really hard, wasn't it? I know. I saw how hard it was for you. I'm really proud that we did this, though. I'm proud that you got in the car. I'm proud that you went into the office, and I love you so much. So finding any kind of win is important because that's how we frame, like how we're thinking, how we're feeling frames how we're thinking, frames how we're acting. And so there's just, I think, I'm not trying to be a blind optimist here, but it is important to find those little wins in everybody's daily lives. Finding the right provider, we're on the home stretch here, but finding the right provider, there is a lot of resources out there. I would just say the American Academy of Pediatric Dentistry is the best place to start for pediatric dental care. So they have a list of all of their providers nationwide. Getting into them, though, could be the other issue. And then there's several other, I just have like this is listed the same way right here. It's just it's more colorful for you. And then the links are there too. Just depending on what you have going on, reaching out to DHHR or HRSA, Insure Kids Now, Dentist Locator, Family Voices. You'll have your own kinds of advocates within your social networks. And I have a few other support things coming up. Things that you might want to ask your new dental provider is, do you see patients with these conditions? I'm not going to lie. I feel like I did my training in inner city Oakland and San Francisco, thought I had seen it all. And West Virginia has thrown some newbies for me. But I mean, I think it's a really great place that we can kind of learn together. And you have a really great children's hospital here with specialists that are willing to work together and create good outcomes for your children. What accommodations do you have if providers haven't really thought of that? You know, like, okay, maybe you are catching them off guard and it's like, okay, well, here's what works for us. Do you think we can do that? Sure. Can we do a desensitization visit? Is there a charge for that? Can I take a tour of your office? What kind of sedation options do you have if my child has needs that they can't tolerate a traditional, outpatient experience for? And then can I share any kinds of care cards? I love those care cards. Just kind of wanted to throw out there that innovation is happening, and with the onset of AI, I mean, the landscape is going to change dramatically faster than I feel like I can anticipate, even though dentistry is kind of sometimes slow to change, but it's happening. It's out there. We're all moving. So teledentistry really expanded during COVID-19. And so you can see even in medicine, how often are you taking telehealth visits now? So those are options with a lot of offices as well. There's also mobile dental programs that try to see maybe it's school-based or group home-based. So that could be an option as well. There's virtual dental homes. This one was by Dr. Paul Glassman. And so they're demonstrating dental hygienists and assistants connected via telehealth are helping to maintain healthy community settings and reducing the need for general anesthesia and sedation. Purpose-built programs are emerging. So this is my alma mater at UCSF Pediatric Dentistry. The autism program employs a board-certified behavioral analyst, which are a behavioral analyst and therapist, I think, to create desensitization plans and programs to help their patients accept treatment. I genuinely wish all the time that we could have like an ABA supported therapist, with our offices as well. Also, oops, that got cut off. I'm sorry. As technology improves, you're going to see just different ways of achieving health. So I anticipate, just like my chart, right? So you have access to my chart and you can see so much of what's happening. Dentistry is going to start doing that as well. So you'll see more. In my mind, everything is individualized, but it's actually probably not. But more empowerment through doing things that you can get at home, like think about 23andMe and the biomarkers. So oral genome is out there with salivary diagnostics. So you just send a salivary sample. Saliva is really important in it has a lot of biomarkers and identifying factors about how it's functioning and how the body is in general. But with these biomarkers, it's going to give you an indication if there's other like types of systemic processes happening. Additionally, it's probably going to help tailor your oral health hygiene at home. Excuse me. For instance, do I need XYZ to help ABC? Maybe I have a G tube or I have a GJ tube. I don't eat by mouth, or my child doesn't. With this, is there something that I can do to combat the amount of tartar in the calculus? And so it'll give you real-time recommendations, like this is oral genome, and then it'll give you personalized reports about how to go forward. Additionally, there's connected toothbrushes like the Truth Brush, where you have an app and it's like in real time monitoring how you're brushing and then giving you feedback. All of this could be shared, just like my chart a little bit. Like it could be shared with your oral healthcare provider so they can evaluate how you've been doing brushing the past 3 months or how you've been doing the past 6 months. What are these salivary markers? Can I prescribe anything that might help you? So it's not here yet, but it's coming. And then just additional support. I'm always fascinated when I look at the CED's website about their resources that they have available and the trainings that they have, the parent support networks, the parent network specialists. advocacy organizations, and then DHHR, they have a children's special healthcare needs program. And then out there is financial and emotional supports that can help you. It can be, as a parent, as a caregiver, it's difficult. And the more needs that your child has, then, that too is excuse me, is also a lot of work, and that doesn't go unseen. I know that you're doing well, and it's day to day. Sometimes there's challenges. Celebrate those little wins. So just key takeaways. The dental challenges are common. They're out there. We know about them. They're documented. It's just not your fault. Again, the system is broken in a lot of ways, and we just have to keep working to catch up. Sensory accommodations and desensitization tactics don't need to be these luxury things and brand new offices. They can be little things that the office can do for you, and also things that you can start at home, like start practicing. What is it going to feel like? Maybe lay down and start brushing teeth. This is what it's going to feel like. You can get a headlamp too. The right tools, positioning products, they can change drastically what you're doing for you and your family. Again, I've said it so many times, you know your child best. You are their advocate. Thank you for being their advocate. And then if you don't have a provider who's listening to you, and you feel like you've tried to communicate that, like, oh, I just feel like I'm not being heard, then find somebody else. That's okay. Sometimes it's an off thing, but we're always there to help. I did want to let you know that I meant to put a slide in here. I'm so sorry that some things, one of the beneficial things, it's really hard to get into my department at the School of Dentistry. I cannot tell you just how many hundreds, if not thousands, of referrals that we have, and we're trying. But if you ever have an issue of urgent nature, we do take walk-ins Monday through Friday, 9 to 3:30. It's a first come, first serve basis that we run in addition to our normal clinic. And then if it's after hours or on the weekends, we have a resident on call with children. So you would just call and ask to page to the pediatric dental resident, and they can talk you through anything, and then I'm always on call too, or one of the faculty members if the resident's not aware. So I think it's a really nice service for those, even if it's like, oh my gosh, I just had dental surgery with this other place. I can't get a hold of them. Can you tell me this is what's happening? And we're happy to talk you through that or see you. Great. Does anybody have any questions? Thank you so much for participating. I meant to leave 15 minutes for questions. You got 5. I'm a talker. So there are only 10 pediatric dentists listed on the AAPD site for West Virginia. That might mean, if that's the case, I know there are more than that, but they might not be on their list. Like maybe they're not an active member. But yes, there are others. I would just type pediatric dentist like in the area you're looking for. So again, I think there's only one in the Northern Panhandle, and they're not taking new patients, but one of my residents is going to go work with her. So up in Wheeling, so they will be. There's only one in the Eastern Panhandle. There are 3 here with WVU, but again, like we're not running a private practice. We're just working in the hospital, and then the outpatient clinics and teaching. There are 2 others here in town. There's one in Bridgeport, and then Charleston, Huntington, like Beckley areas are really where they're at. So the more rural areas, there really aren't any options.
So I wanted to expand on that a little bit because thank you for including the CED in your resources. And so as I was trying to go back and see on our website, we do have a section for find a provider. And when I was looking for the dental, our link is bad. So the link doesn't work anymore. We had a link to free or sliding fee dental clinics. And so then the page on the Department of Health that we linked to didn't work anymore. So
Okay.
I was trying to kind of figure out from your resources where would be a good place for us to link for dental resources in West Virginia. And so I went to the oral health program, but they have it says for children enrolled in West Virginia Medicaid or CHIP, follow the link below, which goes to Insure Kids Now. But then that didn't seem to bring up any providers. So I was wondering, I'm going to go through your slides and pull out some of those resources, but then I was hoping if people did come to the CED and they were looking, I'll definitely link to the 24 that I found or 10 that I mentioned. But are there other directions that I should point people to, and if not, are there things, sometimes if you're looking for like a pediatrician, you can also look for a family health provider, or something like that. Are there other things that people could ask for or look for that may be able to get into easier?
Yeah, so I would say the AAPD site would be the best as far as I'm unhappy that there are only 10 listed there, but that might be the easiest for first part. I think what you're asking for is like, okay, if I'm using a pediatrician, can I just do like a family health practitioner where they treat the whole family? So you'd be looking for general practitioners, just general dentists in the community, but we don't have a list of them that say like, yes, we accept children, or yes, they can't say like, I don't accept children with, a disability. They're not allowed to anymore. So it becomes like in practice, like kind of what Sean Boyne's at across or beyond the waiting room, like what that study is like. So everybody is able to do it. It's just, do they do it or do they not? So I don't have a good list of general dental providers that, treat children especially, but then children special care needs.
I think maybe then that's where your tips on the questions to ask and call and things to do to prepare could really help when people are just calling around to dentists in their areas.
I think so too.
And do you mind if I used some of your slides to pull out some tips and tricks or make a tip sheet? If I could collaborate with you, send you a draft, and we could partner to kind of
Yeah,
put something together. So that way if there's not much out there right now that we can find, then we can develop it together and put it on as a resource for families.
is it okay? Bethany is asking, is it okay to use nanohydroxyapatite toothpaste in addition or instead of fluoride toothpaste? Yeah, so they work kind of two different ways. Fluoride actually changed. So hydroxyapatite is the crystal structure of enamel. It starts out as carbonated apatite and then a hydroxy group as chemistry, blah, blah, blah. So hydroxyapatite is more caries or cavity resistant than regular apatite or carbonated apatite. Fluorapatite is now, I kick off my hydroxy group and I add fluoride, and it's even more resistant to cavities or to acid attacks. So I think I would use it in addition to, because unless the nanohydroxyapatite also has fluoride, I'm not sure. But that's a really good question. The nanohydroxyapatites, they've really like taken off. I still haven't seen a ton of research on the efficacy of them. And like, cause you kind of need to do it. It would have to be like a study of extracted teeth and applying it and then seeing, but then you would also want just normal studies to see, does it change cavity risk or something like that? All right.
I just posted the archive where we keep the virtual speaker series. So within a week, your session will be on there. So if anyone wants to share it with families, or if you want to take a look at it again, that's where you can find it, as well as all the past virtual speakers series sessions as well.
Yes. All right. I think I'm back there. All right. That sounds great. Thanks, Sally.
Mm-hmm.
Well, I hope everybody had at least maybe one take-home point.
Yes, it was very beneficial. Thank you so much for presenting with us.
Yeah, thanks for the thought. And then, Melina, yeah, let's work on that, what you were talking about. Sounds good. All right, guys.
Thank you.
Thursday. Take care.
Have a good day.